Welcome back to another Explainer. Today we are completely demystifying the clinical pathway of female reproductive care. Now, if you've ever felt a little overwhelmed by the sheer scope of gynecological assessments and diagnostics, well, you're definitely in the right place. We're going to take all those complex medical protocols and transform them into a really clear, structured journey, from the very first questions we ask in the assessment room all the way through to navigating the massive transition of menopause.
Okay, let's take a quick look at our roadmap for today. We'll be covering 1. The comprehensive nursing assessment. 2. Pelvic exams and cultures. 3. Diagnostic biopsies and scopes. 4. Treating reproductive disorders. 5. Internal radiation precautions. And 6. Navigating menopause.
All right, let's jump right into Section 1, the comprehensive nursing assessment.
The clinical journey actually begins right here, heavily focused on gathering a precise medical and menstrual history. And, this isn't just about checking boxes on a form. It's honestly about playing clinical detective. We've got to start by establishing a baseline. One of the very first things we document is the age of menarche. But obviously, we don't just stop there. To really understand a patient's reproductive health, we have to map out their unique rhythm. So we're noting the date of their last menstrual period, the frequency of those periods, the sheer amount of menstrual flow, and the usual number of days that flow lasts. We'll even ask about the use of tampons, which might seem small, but it's a vital piece of the puzzle later on when we're assessing for irritation, infections, or other complications.
But a truly comprehensive history goes way beyond just tracking periods. We have to cover obstetric details, literally counting pregnancies, term versus preterm births, and living children. We're also tracking blood type, Rh factor, rubella immunizations, and absolutely any history of STIs or trauma. And if the patient is older, we need to document exactly when menstruation ceased and whether that menopause was natural or medically induced. Literally every single detail here informs our next clinical steps.
Moving right along to Section 2, pelvic exams and cultures.
So, shifting from the interview to the physical examination, our focus moves to visualizing the reproductive structures while making sure the patient is comfortable. To actually see the vagina and cervix, a specialized tool called a speculum is absolutely essential. But we have to remember the physical exam can be incredibly vulnerable for the patient. Because it requires them to be in the lithotomy position, our number one job as clinicians is to ensure they are carefully draped, supported, and kept as comfortable as humanly possible before we ever even pick up this instrument.
And to ensure absolutely nothing slips through the cracks, the exam happens in 3 distinct sequential steps. First up, we visually inspect the external genitalia. Second, using that speculum, we inspect the internal walls and cervix, and this is the exact moment we collect critical stains and cultures, like the pap smear. Finally, we move to bimanual palpation, where the clinician actually uses both hands to physically feel the size, shape, and position of those internal organs.
Which brings us to Section 3, diagnostic biopsies and scopes.
When those initial exams or pap smears uncover something abnormal, the next logical step is visualizing the internal cavity and grabbing tissue samples. Now, when we need a closer look, we typically rely on 2 main types of biopsies. On one hand, we've got the endometrial biopsy, where the cervix is dilated to scrape tissue right off the uterine lining. This is great for diagnosing irregular bleeding or assessing ovum readiness. On the other hand, there's the cervical biopsy, which targets very specific, suspicious cervical tissues to rule out cancer. And that might involve a multiple punch biopsy to remove several small specimens, or even a more invasive cone biopsy done under general anesthesia.
Now, right before a cervical biopsy is done, an incredibly ingenious procedure called a colposcopy takes place. The examiner uses a colposcope, which is essentially a highly specialized microscope with a powerful light beam to massively magnify the cervix. This lets them precisely pinpoint the abnormal, potentially cancerous tissue, ensuring they know exactly where to take the biopsy from instead of just going in blind.
And to build an even clearer diagnostic picture, we can do something called a caldoscopy. This is considered the simplest, most straightforward way to directly visualize the uterus, ovaries, and fallopian tubes. Under light sedation, a scope is inserted through this tiny surgical incision made right in the posterior wall of the vagina. It allows physicians to instantly spot things like ectopic pregnancies or pelvic masses. And honestly, the most amazing part, that internal incision heals entirely on its own.
All right, Section 4, treating reproductive disorders.
Once we've got a diagnosis, the specific interventions kick off. Normally, the uterus sits at a tidy 45-degree angle anterior to the vagina. But things can shift into 4 common anatomical displacements. We have retroversion, where the uterus tilts backward, retroflexion, where it literally bends backward and folds in itself, antiversion, tilting sharply forward, and antiflexion, where it bends forward on itself. Now, while a lot of times this is asymptomatic, these displacements can cause incredibly frustrating symptoms, like dyspareunia, which is painful intercourse, or chronic lower back pain.
So, for displacements or pelvic floor weakening, which is super common after childbearing, we sometimes need surgical corrections, like a colporrhaphy. And following this surgery, the nursing interventions are absolutely critical. Preoperatively, the patient might need an antibacterial vaginal douche and a cleansing enema. But postoperatively, our whole focus shifts. We have to make sure a Foley or suprapubic catheter is in place until the local edema subsides. We're applying cold packs initially to manage that intense swelling and pain, and then we transition them to sitz baths or heat lamps later on. And crucially, we have to, gently but firmly, educate the patient that they must abstain from sexual activity until they are completely healed, while reassuring them that yes, normal vaginal sensation usually does return in a few months.
Next up is Section 5, Internal Radiation Precautions.
In severe cases where invasive reproductive cancer requires internal radiation therapy, strict safety protocols have to be observed by everyone. Internal radiation is highly effective for the patient, but it poses a really serious exposure risk to everyone else. Because of this, healthcare providers and visitors must rigidly adhere to some very precise limitations. If you're caring for this patient, you are wearing a lead apron, no exceptions. You are strictly limited to a maximum of 30 minutes near the patient in any given 24-hour period. Visitors have to stay at least 6 feet away, and the patient absolutely must be kept in a private room. Safety here is literally an exact science.
Finally, we arrived at Section 6, Navigating Menopause.
This is a major, inevitable transition in the female reproductive journey, and it's a massive shift. We really have to ask ourselves, what exactly happens in the patient's body when menstruation just stops and that familiar cycle of hormones completely alters its rhythm? It's not just the end of periods, it is a total systemic recalibration.
Well, that drop in estrogen sets off a whole cascade of physical changes. Patients very often find that their vaginal tissues become much drier, and the vaginal wall can actually shorten. Supporting pelvic structures tend to relax, which frequently leads to stress incontinence. You know, that sudden involuntary loss of urine when you cough, sneeze, or exert yourself physically. There's also a severely increased risk for osteoporosis as bone density drops, along with emotional instability and irritability. To manage all of this, we often turn to complementary therapies, specifically recommending vitamin E, vitamin B complex, and crucial bone-supporting supplements.
And to tackle that serious osteoporosis risk head-on, a daily intake of at least 1,500 milligrams of calcium paired with vitamin D is highly recommended to help maintain that bone integrity.
Now here's a wild fact that catches so many patients totally off guard. Women who want to prevent a so-called menopausal pregnancy cannot just toss out their birth control the second their periods become irregular. No way. They actually must continue using a reliable form of contraception for a full year after their very last period, because ovulation can be incredibly unpredictable during this whole transition phase.
Wow, we have covered a ton of ground today. From the super precise questions of a menstrual history all the way through the exactness of colposcopies to the entire systemic recalibration of menopause. As we wrap up this explainer, I want to leave you with this final thought. Given the immense complexity and constant evolution of the female reproductive system, how can we use this structured knowledge to ensure every single patient feels heard, understood, and deeply cared for? Because understanding the clinical mechanics is only half the battle. Empathy is the rest. Thanks so much for joining me, and keep learning.